Hi, everyone. Welcome back to the Claims Theory Podcast. I'm Lindsay Gross, and today we're diving into one of the most persistent pain points in revenue cycle management, the front end. My guest is Dr. Ashish Mandavia, founder and CEO of Sohar Health. He started his career in psychiatry in the UK before moving into health tech, and today he's tackling the huge challenge of insurance verification and front end RCM workflows. Dr. Mandavia, thank you so much for joining us. We're so glad to have you on.
Thanks very much. Thanks for having me.
Yeah, no, this is exciting. Getting into what everyone out there wants to talk about, how to streamline their front end. And so, Dr. Mandavia, please tell us a little bit about your journey and how it led to you starting Sohar Health.
Yeah, that's a great question to start off with. My career has spanned around 15 years in the healthcare space, and as you mentioned in your introduction, initially I was a medical doctor and I was focused in on psychiatry in the national healthcare system in the UK. I think one of the key kind of drivers for me to move into technology is that I just wanted to be able to have an impact on patients' lives at a bigger scale than what I could do in my day-to-day sort of clinical life. So I kind of just fell into healthcare technology. Actually, I didn't have any technical experience myself, but I had some clinical knowledge, and I jumped into a startup organization that a friend of mine from medical school had set up. And essentially what we were building out was triaging software for emergency departments across the UK and the US. That was before any kind of like terms like AI or Copilot existed in the marketplace. But essentially we were kind of doing an early iteration of that. It was a great opportunity to learn, understand more about how products in the health tech space can actually help and scale up. And it led me to moving into a more kind of commercial role at a company and an organization called Quick Genius. They're now known as Pelago. They are a New York-based substance use disorder platform that really focuses on delivering telehealth care to patients who have addictions like smoking or alcohol use or opioid abuse as well. So we were tackling a really pertinent issue, particularly around the time of the pandemic. And one of the kind of key pain points that we started to realize was that though we could get contracts in place with employers and try and help patients by them being able to reach out as an employee benefit, the real way in which to reach a larger number of patients was to try and get contracts in place with insurers. So we did the rigmarole of getting credentialed, getting contracts in place, only to realize that it was tremendously difficult to automate and scale a lot of the processes in the revenue cycle management chain. And this is not news to I'm sure anyone listening to the podcast, but it was certainly news for us as kind of, I suspect, naive Europeans coming into the US healthcare market and trying to get our heads around the insurance space. And it's those pain points that we really took in as our learnings as we went into developing Sohar. So myself and my co-founder Lucas, who was also an early employee at Pelago, decided to spin out and create Sohar Health.
Got it. That's such a unique perspective that you've literally been in the exam room, seen the human impact, and then carried that into tech. I think that's where so many solutions out there really miss the mark. They're designed from the outside in without really understanding the daily workflow of providers and patients. How has your clinical background shaped the way you think about RCM and the problems you've chosen to solve?
Yeah, that's a good question. I think one consistency throughout my career has been trying to focus in on the provider's key pain points. I mean, I'm sure everyone here can attest to the fact that providers are generally quite difficult to get to adopt technology and to get them to change in any way, shape, or form the SOPs that they operate by. And technology certainly has a place to kind of support providers in that setting. I think the key thing when it comes down to revenue cycle management is trying to mitigate for a lot of the headache that happens after an encounter has been delivered, after an encounter has been coded up and a claim has been submitted. All of that work has been done in order to ideally get reimbursement and for the provider organization to actually receive money. But unfortunately, like far too often, providers are hit with claim denials, patients are hit with surprise bills. And it seems like a shame that a lot of time, energy, and effort is spent kind of trying to recuperate losses at that point when maybe they could have been mitigated at the beginning. So I think the kind of provider's view on this is, well, let's save ourselves time later down the line and try and invest a little bit earlier on in the chain. And I guess that's a very kind of logical way to look at things. And that is very much one of the kind of key challenges that we look to address here with Sohar, where we're looking to kind of challenge the opacity and the unreliable sort of insurance information that can lead to denial-prone claims.
It makes all of the sense in the world to start at the front end and make sure everything going in is exactly right. And so that you save yourself a lot of rework on the back end, and providers can be paid for the services that they've already performed. So insurance verification feels like a check engine light of RCM. When you ignore it, it's at your peril. If it's wrong at the start, it ripples through the entire revenue cycle. What's interesting is that despite all of the investment in tech, this is still a massive bottleneck. So why do you think front end RCM and verification are still so misunderstood?
Yeah, that's also a very good question. I mean, I think generally speaking, RCM teams and operations teams are overlooked by provider organizations, especially provider organizations that may be slightly more tech-enabled, where they are focusing on perhaps product engineering resources, trying to bring out kind of slightly more novel, cooler sort of technologies to either support patients or to support the provider or the actual clinician in the encounter. And it often goes kind of gets missed about like the role the RCM teams and operations teams have. That being said, the challenge when it comes to eligibility is that it's so distinctly different from a payer by payer perspective. So in our case, we support around 1,000 payers. When you're trying to look up benefits for each one of these payers for specific CPT codes, it can differ. And this is often where existing technology that is most likely built within the existing practice management software or electronic health record, that is the only technology really to hand for an RCM team, other than using like an insurance portal. It is inaccurate in terms of the data that comes back, mainly because what may work for one payer doesn't work for another. Often we hear challenges being faced by our customers where they would run a check, but actually not much data would come back. And not enough data would come back to be able to make this decision, or it wouldn't take into consideration that the encounter is taking place via telehealth versus an in-office visit. These are a lot of the kind of like pieces of the jigsaw puzzle that we have tried to kind of bake into our technology and our solution that we offer to RCM teams. And ideally to try and cut down a lot of their time spent either waiting on phone lines or going onto these portals. What I find a really interesting insight and like one of our key learnings over the last 3 years is that when you pick up the phone and call the payer's hotline, and I know that there's changes taking place in this space as we speak, but often you're speaking to someone who's very inexperienced. They're a call center worker that this may be the first call that they pick up ever. And to be able to understand particularly some of the nuance in specialty care, and be able to return the benefits over the phone that are actually correct and relevant is really tricky. And if you were to offshore this, let's say you were to put together an offshore team to do these sorts of phone calls or portal checks, again, they may not know what they're looking for or meant to be asking for. I've heard of many occasions where there'll be someone on one side of the room who will pick up the phone on behalf of provider X's organization and say, I'm looking for Joe Bloggs' benefits. And there will be someone on the other side of the room who will be representing the payer and saying, okay, I'll look up Joe Bloggs' benefits. And I just think that, in the 21st century, that and I am a clinician, so I know that we as healthcare folks tend to take a bit of time to move into the next century for sure. But like that seems very archaic. And so being able to exchange this data in a much more streamlined and fast way is incredibly important. And And it's taken a lot of time. There are legacy vendors out there who have been working on this problem for quite some time and yet still not fully cracked it. And I think that's in part because of design. The data exchange formats and the platforms that we're building on are quite old. They don't always house the right information. They need a lot of interpretation. So having to kind of bring that all together is a lot what we do as an organization, and we have to listen really carefully to RCM teams and RCM folks to be able to kind of learn those insights to build into our product.
Yeah, and the problem that you and Sohar Health are trying to solve benefits everyone, benefits the providers, benefits the patients, benefits the payers. They're having to staff as well to deal with all of the inbound phone calls and staff bots and even offshore resources to manage all of these things. It's something that is needed. And to your point, there are technologies out there that have been in existence today for quite some time that haven't exactly cracked the code. I think a lot of folks have been working on it a long time. I think there are parts that work well and there are other parts that don't. And so Dr. Mandavia, your first company focused on addiction, as you said, behavioral health, two tough areas when it comes to RCM. What lessons did you carry from that into Sohar?
Yeah, quite a few. I would say the one particularly relevant to what we do at Sohar is the existence of payer carve-outs. I mean, we though we now live in an age with AI where every day there's a new article about AI therapists and how it can bridge the gap between pitfalls or gaps in service delivery from actual psychologists and clinical practitioners. It's extremely difficult to be able to ensure that you have a network of psychologists and practitioners available to be able to meet the demand. And demand, it just seems to be going up and up and up for therapy services and behavioral health services. And so trying to kind of, in an automated way, determine if a carve-out is involved in a patient's care, where the claim should be submitted, whether or not the provider is actually in network with that carve-out entity. And we know probably what the kind of like the troublesome ones are, where we're more likely to kind of find a carve-out, as being like a key learning that we've integrated into the building of Sohar. And that's because we started in the space of behavioral health. That was really one of our kind of key drivers for delivering accurate benefits back in real time, was to think about the holistic picture. What other insurances could there be that we are missing in the check that we're running?
Just in terms of all of the experience that you learned with previous health tech companies, previous experience being a practicing clinician has exposed you to exactly what those real problems are, and being able to manage those exceptions. Anyone that's spent any time in healthcare, RCM specifically, knows that it's all about how you're managing those exceptions. Yep. That's why these systems are so important. So I love that you highlight behavioral health because it's such a crucible for RCM problems. If you can solve it there, you can solve it anywhere. And it also forces you to think about not just automation, but empathy and human touch. And so are there unique considerations when building tech for behavioral health providers compared to, say, surgical or hospital-based care?
Yeah, there are. So some of the key considerations, where surgical intervention or hospital visits tend to be one-off interventions, behavioral health tends to be chronic or lifelong. So it really highlights the relevance and the importance of continuously checking this data. Like, if there's any space to do it, it is in this space, because you get typically a high volume of encounters, either on a monthly basis or a bi-monthly basis, and then patients' insurance can change. We're also talking about a part of society where actually this is not just restricted to folks who are over the age of 65. It spans everyone who's within their kind of within working age as well. So changes in insurance don't just typically take place at the end of the year. At the start of the new year. It tends to be that patients can chop and change their insurance multiple times in the year. So that proves to be like a very important part of this. The other thing is the ability to deliver behavioral health care via telehealth. So telehealth throws a big spanner in the works in terms of the accuracy of the data that comes back. Every payer, every plan has its own kind of determination of how they treat telehealth, and that has to be incorporated again in the product. And to your earlier point about edge cases, there is a lot of nuance and edge cases in this, and this is where like often customers will ask me like, so what is the difference between using a vendor solution like Sohar's that only focuses on front end revenue cycle management versus using the eligibility check that I have within my practice management software or my EHR? Well, the reality is an EHR or practice management software has probably about 50, 60 different features that they have to maintain and make as good as they possibly can all the time. They can't possibly focus on 50 to 60 features all at once. Well, we only deliver 4 features, which takes you from the start of discovering a patient's insurance, then verifying their benefits, then determining their network status, and then finally running a cost estimate. If you can only stick to 4 specific features, you can spend a lot of time and resources trying to make those the best they possibly can be. What motivates me, and it's similar in my medical career as well, is the idea of mastery. Like, can we get to the point where we can tangibly stand by our claims that we are 96% accurate with the benefits that we surface up? And that's always a driving factor to every product decision that we make.
Yeah, so along those same lines, and in terms of the quality of the data that you get back, how Sohar Health is going about, this, let's talk automation. Everyone's buzzing about AI and bots and revenue cycle. It's everywhere. How is Sohar's approach different?
Yeah, there's many ways that are different, and the revenue cycle management. So revenue cycle is a continuum. There's so many different stages to that. There's so many different elements in which automation can help, and also probably not help so much. And I think when we first embarked on this journey, I think there was a lot of comparisons being drawn between us and say an AI scribe. And the reality is that actually these 2 elements of the RCM continuum are just completely different. And I think where we see kind of AI scribes really struggling to kind of differentiate from one another. I mean, just this week in the news, Epic came out and said that they're going to be releasing an AI scribe, which of course means that a lot of large venture-backed scaling AI scribe companies are feeling a little bit tense as a result of that.
Absolutely.
Right. It's slightly different in this space. So there's this, I'd say there's probably kind of 3 key things. One, volume. The more checks that you run, the more edge cases you identify, the more that you can build into your product. 2, using and leveraging RCM experience. So working alongside persons such as yourself, who've been a veteran of the industry, and others who have that ability to kind of translate complex RCM concepts into product changes and product improvements. And 3, yes, of course, it's the buzzword, but like AI, but in multiple ways and in smart ways. And we don't normally kind of tout ourselves as an AI front-end RCM solution. Where the AI is being applied is really very much in the back end. It's supporting us to read these file formats that come back from payers, so that then we can make better estimations or better assessments as to what would be the accurate benefits to return. And it's also using a lot of data to train up machine learning models in order to kind of work out, okay, which benefits here with this particular payer plan in this particular place of service is the most likely to be accurate. And we found that to be very effective at cranking up the accuracy of the benefits that we surface, whether that's copay, co-insurance, and deductible. It's across the board that significantly helps. And ultimately, I think it generates really interesting insights. So sometimes we are capped with certain payers that we can only get it accurate about 94, 95% of the time. And then when you kind of really dive down deep into kind of claims data, then you realize actually the payer has been underpaying, or they've been denying claims that shouldn't have been denied. So suddenly providers are equipped with data that they never had before, where they're empowered to go to their reps or go to the payer and request reimbursement. And I really hope, I hope in kind of taking this very transparent and ideally quite simplified approach, that we can empower more and more kind of provider organizations to get reimbursed correctly. Because ultimately, if they are reimbursed correctly, they are more motivated to take on more insurance clients, and we can hopefully bridge that gap and widen access to care, which is kind of takes me full circle to what I initially said, which is that I want to help patients on a wide scale, and that starts with access.
Yeah, and that's brilliant, and I appreciate the transparency, and I can certainly tell that you've been doing this a long time. And that distinction is so important because bad automation just creates more work.
Right.
We've all seen automation that spits out errors faster than humans can correct them. The difference is building smart automation that truly reduces friction. So I couldn't agree more with everything that you just said. It should free up humans to focus on exceptions and not overwhelm them with rework. So building and leading health tech, you've now built multiple health tech companies, and this one is in the US system, which is a beast in it of itself. What has surprised you the most about building here?
There's probably the answer I should say, and the answer that I probably will say. The answer I should say is that being a European and my co-founder is also from Europe, and some of our team members are based in Europe, and we have others across here in the US, is that it still surprises me that you can turn up to your appointment and not know how much it's going to cost you. In Europe, it's so different. You don't have to think about those things, and that's a luxury of the system that's designed there. And of course, there's implications on taxes. But I still think that one of the analogies that I often go back to that someone told me early on this journey is that you could turn up at a gas station. It's like turning up at a gas station and knowing the price of a gallon of fuel to be $1, and then by the time you fill up, it's actually $100 per gallon, and like being surprised by that. And I still find that to be startling. I think the answer that I wasn't supposed to say, but I also find surprising, is that provider organizations were willing to take a chance on perhaps naive Europeans with big ambitions to try and rectify things. And I still feel very, very lucky and fortunate to have worked with some really, really great partners. So we work with Psychiatry, for example, which is very large nationwide telehealth psychiatry platform, and also with Ruler as well, a similar organization that focuses on psychotherapy. And the impact that we've had has been really profound. In the case of Ruler, they've managed to kind of save around 1,000 hours of manual work on a weekly basis through automating checks through Sohar. And similarly with Psychiatry, they've managed to offset about 90% of their operating costs for their offshore team by automating a lot of work through Sohar.
That's amazing.
Yeah, it's really exciting, and I think for me, going back to that point of like that analogy around kind of pricing of care, it's been spoken about for so long, and I feel like change is happening around pricing transparency and trying to improve the patient's experience there. But when we talk about improving the patient's experience, patients now are used to buying via online kind of outlets. So let's take one of the world's biggest online retailers. They are used to kind of going through that checkout process, knowing what they're paying for and expecting that to arrive. And I don't see why it can't be the same in healthcare. So what if we were able to create the digital front door, do the Amazonification of healthcare access? Well, that's my mission, really, to be able to kind of power and fuel that in the background. And hopefully that means that patients feel more confident in the care that they're going for. They can make better informed decisions. 2, they don't end up with so much medical debt or any surprise bills. And 3, that provider can actually have the confidence to take an upfront payment, knowing that it's still going to take about 2 months to get paid for the rest of the claim. So wouldn't it be great if they can support some of their cash flow challenges by having some money up front? So yeah, this is the ambition and the goal, and I'm hopeful that as time changes, we can really be a part of that change in history.
That's exciting. And so speaking of future plans for Sohar Health,
yeah.
And you kind of just touched on this, but maybe more near term, what excites you the most about where you're headed?
So many things. So we've been in the behavioral health space for quite some time. We are now actively moving beyond the behavioral health space. We'll continue to support that, but with the same ethos, the same approach across different medical specialties. We are working with some really interesting providers who are running millions of checks now on a monthly basis to be able to essentially allow any US citizens understand more about their insurance and kind of basically improve their decision making over as to which provider they end up going with. And this is certainly some big news that we're hoping to release by the end of this year in terms of some of the collaborative work that we've done with our partners and how much data we now have been able to kind of process and how many patients we've kind of hopefully allowed to be able to seek care when they've wanted. But right now we're around 5 million, on track for 5 million. I suspect by the end of the year we'll be closer to 10. So it's really, really exciting times for us, and we're very much hopeful for what the future holds, and more kind of tooling that we can build out for provider organizations. Maybe leveraging a little bit more AI, but still kind of trying to maintain that AI is not for everyone, not for every organization, and may not be the right kind of product type for most teams. But that's where we're heading.
That's exciting to hear. And, I love the optimism because so much of the industry is stuck in firefighting mode. We don't often stop to ask, what if we really did get this right? And speaking of, what we all know to be a true and real pain point, and that is front-end insurance verification. If you are in revenue cycle management, healthcare, you are seeing this every day. One last question, and I think you've kind of already answered this in terms of the problem you're trying to solve. But if you could fix one thing about RCM instantly, what would it be?
I have an answer for this, and I speak about it almost on a daily basis. I hope this resonates with everyone who's listening who is in the RCM space, but the payers have so many names. There are so many plan names. I would love it if there was one source of truth for every single payer and plan name that was kept consistently up to date. Wouldn't that be nice to not have to kind of remember
naming
20
conventions?
years ago? Yes, exactly. Yeah. One payer kind of absorbed another payer, and right. that would be really nice. So rather than solving the medical coding piece or automating pushing through claims, actually just a really simple one like that would be so wonderful.
Love that. I think you're going to get a lot of nodding heads to that answer. Dr. Mandavi, thank you so much for joining me today. Your journey from psychiatry to health tech is such a powerful reminder of why clinical insight matters in RCM. And your work at Sohar Health is tackling one of the most important front-end challenges we all face. So for those listening, if you've ever felt the pain of insurance verification, and we know you have, you'll want to keep an eye on what Dr. Mandavia and his team at Sohar Health are building. Thanks for tuning in to Claims Theory Podcast. If you enjoyed this conversation, share it with a colleague, subscribe, and definitely join us next time as we continue exploring the future of revenue cycle. Thank you again, Dr. Mandavia.
Thank you. Thanks for having me.